What's going on, guys, and welcome back to the world's okayest physical therapist podcast. Today, we're taking a look at ankle sprains, and please don't forget to like, comment, subscribe, share, send this to everyone you know, because I'm trying to figure out how to navigate this labyrinthine, Byzantine, constantly mutating system we call the American healthcare system in order to help myself and other people know the specialists and the people that they're supposed to go to in order to stay healthy, stay fit, and stay awesome. Please consider checking out 10,000. They sell shorts and fitness apparel, and I have a link for you to get 15% off. Shout out to them for giving me the link, and may you guys really check them out. They are phenomenal. And in fact, I'm wearing a pair right now. I love them. So shout out to them for being awesome, and give me that link to share all with you. So ankle sprains. Why are we taking a look at ankle sprains? Because they are among the most common injuries to the lower extremities. Up to 40% of ankle sprains go on to develop chronic symptoms, including pain, swelling, instability, reoccurrence that persists at least 12 months post-injury. Furthermore, 1 in 5, 20% of individuals who sustain acute sprains develop into chronic ankle instability. And that is from Mugno and Constant, from Reoccurrent Ankle Sprains, updated 2023 in August. Why are we doing this? Why am I talking about this? Because in the clinic and in life, I see a lot of people that have ankle sprains and they go on to sprain it again and again and again and again. This is for all of them and for you. The flashback here that I want to focus on. A strain is tendon and muscle. A sprain is ligament. And why is this important? Well, because usually when you injure your ankle, it goes hand in hand. You have a sprain, right, of the ligaments and a strain of some muscle group, usually the peroneals or fibularis, which is the outside of the calf. A lot of times it's also the tibialis anterior, which is the muscle that pulls your toes up towards you. Grade 1 for both of them, mild, some swelling, a little bit instability, usually recoveries within a week, maybe 2. A lot of times I hear say 2, the textbooks vary, but I say 2 because it takes about 14 days for inflammation to be completely resolved. So grade 1 is very mild. Grade 2, moderate pain, a decent amount of swelling, tenderness, bruising, and you have some degree of tearing, either like a little bit all the way up to you've almost completely ruptured it. Grade 2, remember, is a wide window. We've done this before in a different podcast. You can go back and watch that podcast if you really want to delve into this again. Recovery. It depends, right? It depends on the person's previous level of fitness. It depends on their nutrition, their sleep, how much their activity they're doing on a day-to-day. It depends if they re-roll it. It depends on a whole host of factors. That's why the medical field is called practice. Welcome to my practice. I'm practicing. I'm learning how to get better at this. It's very frustrating for everybody involved. PTs want to give you an answer, but they know that they can't. And patients want an answer, and they know that they should get one, but they don't quite get one all the time. So usually I'd say here within like 4 to 8 weeks. I agree more with the one where it says 2 to 6, where it's like, okay, 4 to 8 is where I would expect that to fall. And then grade 3 is, of course, a complete tear, a rupture of the tendon or the muscle. And it usually requires surgery, though not always. I think that's a pretty quick, easy recap of that. So that's why someone says, I have a grade 2 strain of my fibularis longus. The PT is going to be like, oh, okay, what about how much? Do you know? Does it say on your form like 25% tear, 30% tear, 50% tear? And they're like, oh, it's a 90% tear. And they're like, oh, that's pretty significant, right? Bigger percentage of the tear, closer you are to grade 3, the longer it might take to rehabilitate that versus, hey, I walked in, I had a 5% tear. And it's like, oh, it's like a little baby tear. Okay, well, then that recovery will probably be shorter. It depends. Different types of ankle sprains. There's the lateral ankle sprain, the medial ankle sprain, and the high ankle sprain. The most common, of course, is the lateral ankle sprain. That's where your toe comes in. It comes down and in, pointed in, and the actual ankle itself rolls out. As you can imagine, any of the structures that are holding the ankle together on the outside are going to be put under a decent amount of stress and strain. This also includes the fibularis longus brevis and tertius, which are the muscles that run on the outside of the calf in that general area that are trying to resist motions that pull you into inversion. Those muscles' job is eversion, which is pulling the ankle up and out to the side. In addition to that, two ligaments that are very likely to be sprained are the ATFL and the ATTL. If you point your toes straight down and then in, that's ATFL territory. That's a little bit more diagonal. And then ATTL is just straight down with the toes. And you can see how if you roll your ankle, if the toes are pointed straight down and then in to an extreme degree, both of those ligaments, which run across the front of the ankle that are designed to resist that motion, would be strained, right? If they're designed to help you be stable and resist that motion, and you put them through excessive motion, you can see how they're going to be strained. Now, the most common one that's injured is ATFL because the most common injury is the toes down and in, right? ATTL is a close contender because it's also in the vague area, also kind of resisting similar forces. So it too can get strained. Most of the time in the clinic, if I'm assessing someone, they're uncomfortable with both. How much of that is because both are strained versus ATFL is just so inflamed it can't tolerate being put in that position anyway? Who's to say? Does it really matter? Not necessarily, because if the ankle sprain happened that way, the PT is already going to know this is the trouble issue. This is the area. Hopefully the PT and the person coming in would have imaging performed saying, hey, we know this one is a grade 2. But if you're just walking in fresh off the street and the PT is putting you through these paces and they're like, oof, this looks pretty significant, actually. This is pretty painful. You should go get imaging. Then what they're telling you is, hey, I think you have a ligamentous issue. A good PT is going to ask you where you're feeling the discomfort and pain, because if they go and do this special test and you feel it in your heel, that's not a positive. A positive would be across the front of the ankle, for example, because that's where the ATFL and ATTL live. The medial ankle sprain is often a more severe injury, and it happens on the inside of the ankle. Why is it more severe? It takes a lot more force for that medial ankle to get ripped and yanked out into the side. It's a lot more of a bony, close packed joint when it moves that way. So a force that's getting you to go in that direction is going to be pretty substantial. The deltoid ligament is what runs on the inside of the ankle joint there. And again, it's pretty strong. So it's a more severe injury typically when you see medial ankle sprain. Now, people do get both medial and lateral ankle sprains. A lot of the time they're athletes. A lot of the time they're doing something downhill, like running downhill, hiking downhill, skiing, whatever. And they get a double whammy. The toes come down and in, and then they try to correct by having their toes go down and out because they know they're rolling their ankle, and they can get a bam, bam, double whammy, and they have a medial and lateral ankle sprain. But you can already see here that you could possibly have a grade 2 strain, grade 2 strain of the fibularis with a grade 1 sprain of the ATTFL. Well, that's going to change your course of PT. That's going to change your timeline. That's going to change the plan of care. That's going to change the it depends answer from a medical professional. Because as a medical professional, I myself am going to go with what's more restrictive. If you have a grade 2 tear of a muscle, I'm going to be focusing on that versus a grade 1 sprain and tear of a tendon or a ligament. I'm going to be paying attention to the one that is more severe, and that is going to drive my answer. So if I was a patient, for example, and I walked into a clinic, I know I had a grade 1 sprain of the ATTFL and a grade 2 strain of my fibularis brevis, and I Google that in, I'm like, well, it says here that my ankle should be better in 4 weeks because it's just a grade 1 sprain of my ATTFL. And if the PT pushes back and says, that's true, but you have a grade 2 strain of this, which is 6 to 8 weeks, that's where the Google sleuthing can run you in a wrong direction if you don't take the time to evaluate both, and I see it all the time. High ankle sprain, that is a syndesmotic injury. Typically speaking, I guess, depending on the severity of that injury, it can be longer than the low ankle sprains. But typically what I see is the more vascularized structures, which would be higher up in the leg, they recover pretty quick, depending on, again, the severity of the sprain or strain. So it depends with that one. If you are having a high ankle sprain, it typically is going to be a pretty significant injury that caused that, which is why it can take so long. But if it was a lower threat, a lower severity sprain, typically it will actually recover faster because it has increased blood flow. But as you can see here, football, skiing, and cutting sports like basketball, soccer, yeah, if you go in there and really tear up that high ankle, it's going to take longer to heal. But as a general principle, if the more vascularized areas take less time to heal, but because the high ankle has so much connective tissue that holds it together, and it takes such amount of force to go in there and injure it and to tear it, the injuries tend to be a lot more substantive, which is why it takes longer. So let me know if you guys have any questions about that in the comments section. A very loose timeline. Remember, the grade and what was injured drives the plan of care. Okay, so a grade 1 injury is going to be very low threat. A grade 2 can be moderate to severe, right, in terms of how much that muscle or ligament is torn. And then 3, you're basically dealing with surgery, and whatever the surgeon gives you as a protocol, which I'll do an episode on later, is going to guide what you're going to do. In the acute phase, which is, it says here 72 hours to a week. I usually put that from 48 hours to 2 weeks because it takes 2 weeks for the inflammation to really calm down. One of the things that is becoming more and more agreed upon in at least the PT world is, instead of RICE, which is rest, ice, compress, and elevate, you should do MEAT, which is movement, exercise, analgesia, which means like icing or using some sort of way to control the pain, and treatment. The idea being behind that, hey, don't let something just sit there and atrophy and get stiff when you have the ability to move it to some degree without pain. Some movement is better than no movement. Some exercise is better than no exercise. Treatment is better than not treatment. And that's the idea behind MEAT. Now, me personally, for myself, this is not medical advice. This is me speaking personally. If I have an ankle sprain, I am going to try and do a couple of exercises right off the bat. I'm going to try and do ankle alphabets, and I'm going to try and do isometrics. Why am I going to do those? One, I want to see what range of motion I can move my ankle in that is pain-free, and I want to preserve that range of motion. As long as I know I'm not causing more injury and more harm, and I'm safe doing so, I'm going to do so, because I know if I let my ankle just sit there, it's going to get tight. It's going to get used to not moving, and it's going to adapt to not move. Isometrics, I'm going to start performing because I want my brain to be talking to the muscle. And this is a very important part. Let me take a drink of something real quick because my throat is very dry. Isometrics are a very important tool to get the brain talking to the muscle, even when there's inflammation present. Edema and inflammation in an area is effectively the cells talking to each other, saying there's significant trauma around me. What am I supposed to do? Without going too deep into it, in that fluid, there's a lot of hormones, there's a lot of cell signaling, there's a lot of things going on. And the cells are basically telling each other, shut down, don't move, don't work. There's an area of trauma around this. We have to let whatever is dead be gobbled up and destroyed, and we have to give time for there to be new cells to form and for new connective tissue to be laid down before we can accept the same load that we're used to handling. What isometrics do is a couple of things. One, they allow the brain to talk to the muscle through the process of healing to make sure it maintains that contact. Instead of just turning off any signals going to that ankle for 3 weeks, I'm trying to get my brain to talk to my muscles to make sure they fire voluntarily when I want, how I want, and to the percent that I want. If I'm doing a very low-grade contraction that's pain-free, perfect. I'm going to keep trying to push the envelope just a little bit to find out how much I can push comfortably with no pain and in what directions, and I'm going to hold that for time. The second reason why I'm doing that is I'm also incurring an analgesic effect. My brain is learning where it can move and how it can move, when it wants to, how it wants to without pain, which allows my brain to not be dialed up to 11. It's not trying to worry about, is this movement painful? I've never moved this way before. It's saying, no. I've done low-level muscle grade contractions here, and here. I know that I should be able to contract just a little bit more without pain. Okay, there we are. that helps the brain calibrate itself to know what is painful, what is not painful, what it can do, what it can't do. And it's not sitting there in an apprehensive state thinking everything and anything is painful. I've explored just enough to let it know that it's calmed down, that's not painful. And then 3, what it's also doing is it's allowing me to contract the muscles to drive more blood flow to the area to hopefully, possibly increase healing just a little tiny bit more. And all of that I'm doing just as early as I can. So here you can see in the acute phase, like it says, rest, compress, elevate, avoid long-term immobilization, less severe is what it says here. And then basically looking at pain and swelling management. In the subacute phase, which is 1 to 3 weeks, that's where it's gentle mobility, range of motion, exercise, which it considers alphabet writing, ankle circles, basically the things I said I'd be trying to do just as fast as humanly possible. And it says here also early weight bearing as tolerated. Again, that's going to be largely driven by if there's any imaging or significant tearing, grade 2, grade 3, right? If you have a grade 1 strain or sprain, you're probably not going to be restricted from weight bearing. It's probably going to be like, yep, it sucks, but you're going to have to still get up and move. If you're looking at grade 2, that's where you're probably looking at like, hey, you might have to wear a brace. You might have to wear a cast. We don't want this to get any worse than it is. So that's where that it depends part for the subacute phase. Typically, if you have a grade 1 strain, a lot of people try to walk it off and just live life normal, which is why the percents that we talked about earlier happened. But if people have a significant ankle sprain or strain of muscles, they're going into their doctor, and that's why that bias is driven that way for don't move for a week, right? Strengthening phase. Now, this is the part that I agree with. Usually 3 to 6 weeks. I would say usually 2 weeks to 4 weeks is when you would start that. But again, it largely depends on the grade and the severity. If you're given a protocol by a surgeon, for example, which I know I said I'm going to do an episode on in the future, I will. I'm going to follow that. If instead it's a patient coming in with a low grade strain, I'm probably going to be strengthening relatively sooner than I would someone who had a more significant strain, right? It's just common sense. But the isometric exercises that were built up before that neurological handshake, that learning to recruit the muscles voluntarily into the degree that you want, again, is what lays the groundwork for this strengthening phase to be so much more successful. Because now I'm going in there and strengthening the fibularis, the peroneals, the calves, the intrinsic foot muscles, hamstrings, dorsiflexors, all of those things. I'm going back in there and strengthening whatever was weak, and I'm doing it progressively. I'm not trying to get the brain to flare up and say, oh my gosh, this is so painful. Again, I'm sticking to what is light for myself. And I'm also starting to work for myself on seeing if I can work my balance, for example, my proprioception. I want to know where my ankle is in time and space. I don't want to have a lack of a sense of knowing where my ankle is, because that's going to set me up for injury in the future. So I might do some balance stuff. I might do like my ankle alphabets, getting used to like doing it with my eyes closed, seeing if I can feel where it is. Instead of having just this empty feeling of not knowing where anything is on my ankle, I'm going to try and actively train myself to be like, okay, I know my ankle is maximally out here. I know it's maximally in there. I know my range of motion I'm working here. I know I'm working it there. So that way, when I'm walking, I can just mentally know my ankle is in this position versus this position. And then finally, I would be working on returning back to sports. So if I was looking at running again, soccer again, whatever, that would be the 6 weeks plus for myself. I would be like, okay, I know now that my strength is back to where it needs to be. My tissues have healed substantially enough. There's no inflammation. There's no edema. I know I'm getting ready back to doing what I want to do. And then the big question is, how do you keep it from happening again? How do I keep it from happening again? Because like we talked earlier, 40% of ankle sprains go on to develop chronic symptoms. And it's because I believe people don't take the time. One of the biggest things that I see is people, the minute they start feeling better, they try to go right back to doing what they were doing on their ankle. And they set themselves up for failure and they re-injure it. And the brain has now learned a very important lesson. Re-injury is very real. It happens when I was confident, and now I shouldn't be confident. And that's the mental component that I personally see all the time. Instead of, hey, I took the full 6 weeks, I gave myself 6 weeks, 8 weeks, whatever to get back doing what I love, I rushed it at 2 weeks because I felt pretty good, and now I'm right back to square one. PT is predicated on the assumption that what people are going to do is they are going to take their home exercises and make it part of their daily life. How unreasonable or reasonable that is. A lot of times ankle injuries are due to lower extremity athletes and runners have one very critical flaw as a majority. They don't weight train. And because they don't weight train, they don't keep the strength in the ankle. And that's why they typically roll it. So the how to keep it from happening again is this isn't a tune-up. This isn't you're coming in and getting your oil changed. This is you have to have significant life alteration in terms of what your fitness regimen is in order to prevent it from coming back. You've had a history of one injury. That means you're set up for a history, you're set up to have a second injury. You're now more at risk. So how to keep it from happening again, the short answer is if you've been cleared by a medical professional, you exercise. That's what I do. The reason why I exercise my ankles personally is I don't want to sprain them, I don't want to strain them, and I don't want plantar fasciitis. And all three of those things don't happen if I strengthen my ankles. So to circle back to the why, up to 40% of ankle sprains go on to develop chronic symptoms, including pain, swelling, instability, and reoccurrence that persists for over 12 months post-injury. I don't want that to happen for me. I don't want it to happen to people in my clinic. So I am a huge proponent of strengthening and strengthening as appropriate along a decent timeline. And again, that timeline is going to vary because it depends on the person. And furthermore, approximately 20% of ankles who sustain chronic ankle sprains develop into chronic ankle instability, which me and my goal in the clinic in which I work is to prevent that from happening by using strengthening as a tool to improve stability as best as I can. And as for myself, I don't really have ankle instability. I just have a history of more like plantar symptoms. So I'm on it on myself because I know that in order to prevent those things from happening, I have to be strengthened. So this has been the episode on ankle sprains. I am sorry if it's a little bit preachy. I am sorry if it ran a little bit long. I have been dealing with a lot of ankle sprains recently. And I want to get this message out there because I feel like it's super important. A lot of times people want to rush right back into it. They don't want to take the time. They don't understand the why of the isometrics or the ankle alphabets or the proprioceptive training. And as soon as they feel pretty good and the swelling looks like it's coming down, they want to go right back to doing what they were doing. But you have to give your ankle time to heal, to remodel, to rebuild that neurological connection, rebuild that strength, and then slowly get back to those things under the care of a medical professional, right? All of this is predicated on the idea that you're under the care of a medical professional. They've cleared you for exercise, right? None of this should be taken as medical advice that you should do on your own. So this has been Ankle Sprains on the World's Okayest Physical Therapist podcast. Thank you so much for listening and watching. Please don't forget to like, comment, subscribe, share. Check out 10,000. They're absolutely amazing. And check out the Patreon as well. That space is kind of popping off recently, so it's really exciting to see you guys jumping on there and texting me and saying, hey, I got a question about this, hey, I got a question about that. So everybody stay healthy, stay fit, and stay awesome, and I will catch you all in the next video.